Welcome to this session of the Coffee Break series of presentations. The focus of this presentation is on one of the most important publications to clarify issues about a long-standing debate regarding cervical spine manipulation and stroke. Risk of vertebrobasilar stroke and chiropractic care. Results of a population-based, case-control and crossover study by Cassidy, Boyle, and Cote et al., published in Spine in 2008. This study evaluated over 100 million person years over a period of 9 years. The source population were all the residents of Ontario. They found that there were only 818 vertebrobasilar strokes who were hospitalized. This is evidence for how rare VB stroke is. By the matching of hospital records indicating VB stroke with the same patient records of a visit to a chiropractor and/or a primary care medical practitioner, the relationship to having seen either provider could be tracked. So what are some of the take-home points? In those under age 45, individuals were 3 times more likely to see a chiropractor or a primary care practitioner before their stroke compared to controls. There was no increased association between VB stroke and chiropractic visits in those older than 45. However, there was an association between VB stroke and patients of all ages visiting a PCP prior to stroke. Now remember that cause was not studied, only the association between stroke, time, and a visit to either a chiropractor or medical doctor. For a great review of the stroke issue, please read Don Murphy's article on the current understanding of the relationship between cervical manipulation and stroke and what it means for the chiropractic profession. So let's summarize. VB stroke is extremely rare. Given there is at least an equal association between chiropractic visits and PCP visits in stroke, it's unlikely that there's something unique to the chiropractic treatment that would contribute to a cause of the stroke. And given that patients who subsequently had stroke had complaints of headache and/or neck complaints, it's likely that dissection or intimal tearing was occurring at the time of presentation and not due to the intervention in the MD's or chiropractor's offices. Neck cracking may up stroke risk. Most people will say they've heard something like this, but don't know much about it. It seems reasonable that when you twist someone's neck and produce a cracking sound, that other tissues might be harmed. So, armed with a layman's rationale, many neurologists put 2 and 2 together and assume that any patient who had seen a chiropractor, even within the last month, would be at risk for a manipulative stroke. Well, when rare events occur, it is natural for us to scramble for a rational explanation. But as we've seen in other presentations, the problem with the case report approach to evidence is it assumes once is enough, or if I see what I think is a pattern, then all the variables are accounted for when clearly they are not. The detractor here is that there seems to be a reasonable traumatic explanation, so therefore cause and effect are drawn close together. And add to that the element of an event occurring close enough in time, and it seems reasonable. But what if, though, there was a reason for someone to be in your office while they were in fact experiencing the event in progress? Well, that's the rational conclusion that we can draw from this study. Patients with a dissection in progress may be asymptomatic, or, as has been shown, 80% of them have complaints of headache or neck pain. Now, most people would decide that it'd be reasonable to go to their healthcare provider to seek relief. So could it be that if other healthcare providers, including MDs, who saw these patients were also included in a review of cases, we would see a similar association between them and stroke patients? MDs do not customarily apply mechanical forces to the necks of their patients, so if it turns out to be true that there is an association, it's unlikely for those cases to be related to any obvious mechanical forces. Now let's look at what has transpired over the last 25 years or so to see why this study is so important. Well, first, there were a few case reports indicating stroke events that seemed to be associated not only with manipulation but with other rather benign events related to activities of daily living. Also, in many instances, the manipulation was performed by someone other than a chiropractor. Well, because it was so rare and associated with other minor positioning of the neck, not much attention was paid. Well, next came surveys. Surveys, as you know, are ripe with recall bias, especially when extended to over a 2-year or greater period. First, in Switzerland, the Swiss Society of Manual Medicine asked its 367 members about their recall of neurological complications following cervical manipulation. Now, this was a recall over their careers, which averaged 8.1 years and could be as long as 33 years. The response on how often they saw serious complications was estimated at about 1 in 400,000. Next was a survey of California neurologists who were asked to recall cases over the past 2 years in which they believed a chiropractic adjustment preceded the stroke. With only a 37% response rate, 21% reported at least one stroke. Now consider how this survey is a form of profiling where the focus was on looking for patients who had seen a chiropractor. It's not only a prejudicial approach, it's totally unscientific, but also creates a heightened awareness and bias when viewing future stroke cases. This was followed by a Danish Chiropractic Association survey for the period of 1978 through 1988. With a 54% response rate, they estimated one case per 1.3 million cervical treatment sessions. Well, next was a call for something, of course, more scientific. For risk, a prospective study would seem best, but they're difficult to run when the event is so rare. You could literally follow thousands of patients for years and find no cases of VB stroke. An appropriate design would then be a case control approach, which, when able to access a large enough database, could look across years and track that event. This is a retrospective approach where patients' records are traced back in time to find the patients with the target disorder and whether they were exposed to a proposed risk factor. The first of 4 case control studies was by Rothwell et al., entitled Chiropractic Manipulation in Stroke. As we will see, some of the observations from this study laid the groundwork for the Cassidy et al. Study. This study extended over 6 years and focused on stroke patients who had visited a chiropractor prior to the stroke. They used a control group who were different than the stroke patients. They found that patients under 45 years of age were 5 times as likely to have seen a chiropractor in the previous week, but no difference in those 45 years or older. They also mentioned that patients seeing chiropractors had symptoms of dissection, headache, and neck pain. Only 5 cases were attributable to the chiropractic visit over a 5-year period. That's 1 per year. Over 95% of VB stroke victims did not visit the chiropractor's office within 1 year of the incident, and only 3% saw a chiropractor from 1 to 12 months preceding the stroke. Smith et al. Published in 2003, Spinal manipulative therapy is an independent risk factor for vertebral artery dissection in the periodical Neurology. This was a 6-year study at 2 academic stroke centers where there were 51 patients with cervical artery dissection. Again, that's over 6 years. 25 involved the vertebral artery and 26 the carotid. They concluded patients with VB stroke were 6 times more likely to have visited a chiropractor within 30 days of the stroke. The author's conclusion? The study shows that spinal manipulative therapy is independently associated with vertebral artery dissection. Patients should be consented for risk of stroke or vascular injury from this procedure. Well, what followed was a public airing and a focus on this statement. WebMD Medical News had a headline that stated, "Neck cracking may up stroke risk." The first line, "If you've got a pain in the neck, think twice about getting your neck cracked. SMT, as chiropractors call it, increases your risk of stroke." At the end of the article, it says risk is very small. Both the principal author, Smith, and Scott Haldeman were interviewed. Smith stated, "We think it is a very low risk," but goes on to say patients should be aware that spinal manipulation increases risk of stroke. Haldeman stated, "I think the information in the Smith study is very important. It does confirm that there is a temporal relationship between stroke and spinal manipulation that cannot be ruled out, but their evidence that SMT is a major cause of stroke is very weak." The third case control study was by Dietrich et al., who studied 47 individuals with either dissection or stroke related to carotid artery dissection. They were looking for a mechanical relationship to the stroke, including neck trauma, sexual intercourse, athletic activity, and chiropractic manipulative therapy. Now, interestingly, the time frame for all other events was 1 week, while there was an unexplained time frame for chiropractic manipulative therapy of 30 days. Even though they found no association to any of these mechanical events individually, they found as a mechanical group an association. This, for some reason, led them to state there was a weak association between chiropractic manipulative therapy and carotid artery dissection. Well, what's so powerful and unique about the design of the Cassidy et al. Publication, the fourth case control study? Well, here are some key elements and processes. They used an approach called a crossover design, where patients act as their own controls by using a period of time when they did not have a stroke before the incident event. Crossover is helpful in controlling for confounding factors that could affect the risk of VB stroke. It keeps the affected and control groups equal on all counts, such as cardiovascular risk factors, etc. They evaluated the temporal relationship and also looked at those cases that happened immediately. They found no difference between immediate onset of stroke with regard to being at a DC or MD's office. They used data for all Ontario residents captured in the Discharge Abstract Database and Canadian Institute for Health Information Database. This then required an approach which uses person years versus persons. Person years are used so that the data would include those individuals entering or leaving the system over time. Now, after gaining access to such a large database, what are the next steps? Well, first, identify those that had a vertebrobasilar stroke using hospital coding. Next, look into the database to determine prior to the event, did the patient see a chiropractor or an MD or both? And note here that this database does not include other providers such as physical therapists or massage therapists. Use a reasonable time frame for that visit. Similar to other studies, 30 days was the hazard period chosen. Taking one more step, use the ICD codes from these offices and determine if the doctor coded the patient as having some form of a neck or headache complaint. In this way, a relationship to presenting complaints and subsequent stroke might be identified. So let's cover a few terms used in this study you may not be familiar with. Bootstrapping. Well, bootstrapping is a computer-assisted approach to taking a small sample, as we have in the study's stroke patients, and creating basically copies of that sample group, and then through the use of computer programs, randomly assigning values to statistically determine standard errors and confidence intervals. Basically, a computer simulation of a larger sample. The results are reported in odds ratios. Odds ratios are often used in case control studies. They are the ratio of odds of developing a specific disease or outcome in the exposed group divided by the odds of developing the specific disease or outcome in the unexposed group. The exposure is the risk factor. It's determined through a 2x2 contingency table. Now, here are the odds ratios for a visit to a chiropractor within 30 days and its associated confidence intervals. Also, we have the odds ratios for visiting a PCP related to age, younger than 45 and 45 years of age and older. So what does this mean? Well, for studies involving risk, an OR of 1 means that there is no difference between the exposed group and non-exposed group. An OR of greater than 1 means that there is an increased risk in the exposed group, and an OR less than 1 indicates a decreased risk in the exposed group. Well, we can see by these tables an increased risk, except for the confidence intervals for MDs in patients under the age of 45, where the bottom of the confidence interval is actually below. It's 0.94. I'm going to use the remaining time to do a quick overview of dissection and stroke. What causes it? Can you detect it? And what are the signs and symptoms? What do you do if stroke occurs, and what's the prognosis? Well, 25 years ago, the screening approach to patients was based on the belief that atherosclerotic plaque, forming clots that break off, form emboli and cause infarct. Most of the testing, such as the so-called George's of Declines test, were attempting to detect decreased blood flow based on provocation of symptoms, and if present, implicated that there was an underlying blockage from atherosclerosis, theoretically placing the patient at greater risk. Well, what's changed is that these cases are due primarily to intimal tearing. Intimal tearing leads to an intramural hematoma. That hematoma may act as a blockage or occlusion in the artery. Or, if you have a subadventitial dissection, may lead to aneurysm formation and possible rupture. The signs and symptoms are related to the underlying process, so that some are delayed and some are immediate. So an expanding hematoma causing occlusion or a formation of a clot and subsequent thrombi as a sequela to the hematoma, both would be delayed. Whereas local vasospasm of the artery with or without dissection may be immediate. Secondary vasospasm from a subarachnoid bleed would be delayed. Notice that in the list of potential risk factors, atherosclerosis is not included. And this is because the belief now is that intimal tearing is due to weakness of the artery, which is the result of an underlying inflammatory condition or an inherited weakness in connective tissue in the lining of the artery. When patients do present in dissection, they often report neck pain or headache, and this occurs about 80% of the time. They often describe the pain as first, meaning new, or worse, meaning the worst neck or headache pain they've experienced. So what about vertebrobasilar testing? Well, simply put, there's no such thing, at least clinical testing in office. The tests used in the past, such as placing the head in extreme positions, checking for production of VBA signs and symptoms, were based on that old concept of existing occlusion due to atherosclerosis. We now know that it's intimal tearing, of course, and standard in-office testing cannot detect arterial anomalies or pathology that predisposes the individual to dissection and stroke. They can't detect arterial damage that exists prior to treatment. They can't be used to predict whether either damage or even reflexogenic spasm will occur, and frankly, they aren't even good at distinguishing between proprioceptive, benign types of dizziness versus ischemic dizziness. With the onset of VB stroke signs and symptoms, they appear almost immediately, about 69% in the practitioner's office, another 9% within an hour, and 14% within 24 hours. A great mnemonic in common use are the 5 Ds and 3 Ns. Dizziness, drop attacks, diplopia or double vision, dysarthria or difficulty speaking, dysphagia, difficulty swallowing, ataxia, difficulty walking, nausea, numbness, and nystagmus. There are various syndromes that may result. They're quite rare and are based on the specific artery that is occluded. So what should you do? Well, there are many suggested approaches, but most are based on a quick neurologic screening. Here's an easy one to remember: FAST. Well, F stands for face. Ask the person to smile and see if the face droops on one side. A stands for arms. Ask the patient to raise both arms and notice if one arm drifts downward. S stands for speech, and ask the patient to say their name or a simple sentence and notice if this speech is slurred or unusual. T stands for time, and it implies that you should be calling 911 or getting the patient to the nearest stroke center or hospital immediately. Never remanipulate. Place the patient in the rescue position on their side and never give fluids, both of these suggestions in an attempt to avoid aspiration. And always stay with the patient, monitoring any resolution or progression of signs or symptoms until the emergency medical team arrives. Document all relevant information regarding onset and follow-up. You may be surprised to find out that the actual prognosis for VB dissection and stroke is not as severe as most people believe. The death rate is less than 5%. If there is stenosis, it resolves eventually 90% of the time. 66% of occlusions recanalize, meaning the blood flow is reestablished in the vessel, and 33% of the time, aneurysms decrease in size. If this is going to happen, it will usually occur in the first 2 to 3 months following dissection or stroke. So what about the possibility that adjusting or manipulation causes damage to the artery? Well, this has been studied various ways. Here's an example where 8 patients were examined using Doppler and magnetic resonance angiography with full cervical rotation. There were no observed changes in lumen dimensions or flow in full rotation. There was local compression or kinking of the vessel wall with contralateral rotation, but no evidence of stretching due to stenosis. Another study using cadavers used piezoelectric ultrasound crystals to measure strain while the head and neck were placed in typical range of motion, diagnostic testing, and spinal manipulative treatment positions. The strain on the vertebral arteries with the spinal manipulation therapy position were only 1/9 that needed for failure. The researchers conclude that it's unlikely that SMT would, under normal circumstances, disrupt the vertebral arteries. Christopher Good wrote a response to this study and in his critique suggested some needs for future studies. One was based on a theory that not a single traumatic event but an accumulative traumatic sequence occurs with multiple manipulations. A recent study in 2010 addresses that research question. Using cadaveric rabbit vertebral arteries, it was found that no microstructural damage occurred even when exposed to 1,000 strain cycles of magnitude and speed, corresponding to the maximal values observed in the human cadaveric vertebral arteries during simulated chiropractic spinal manipulative therapy of the neck. Now, oftentimes the defense used by chiropractors when accused of causing stroke is that similar treatments are riskier. Examples are that cervical manipulation is only 1/100th to 1/400th the risk of using NSAIDs for headache and neck pain, and that death from cervical surgery is 700 times greater. Well, given the results of the Cassidy et al. Study, this is probably an unnecessary defense. However, it does remind us that all treatment methods, no matter how common, have some risk. I wanted to refer you to some valuable resources. Chiro.org has a wonderful compilation of articles and other resources related to VB stroke. And of course, NCMIC has published the wonderful report by Tourette, Current Concepts, Vertebrobasilar Complications, the classic on the subject. And recently, Triano and Kauchek published an executive summary of that report.